towards the end of the session. Moving on to the next talk by Dr. Subha Kurian. She is the medical retina consultant in Apollo Adlux Hospital, Karukutti.
Good afternoon all. My topic is anti-VEGF treatment regimes in diabetic macular edema. Diabetic macular edema is the retinal thickening caused by the accumulation of intraretinal fluid primarily in the inner and outer plexiform layers. It occurs mainly due to hyperpermeability of the retinal vasculature, and it can be present with any stage of diabetic retinopathy. And based on OCT, DME can be simply classified into tractional and non-tractional. Non-tractional again classified into non-center involving and center involving macular edema. Why this classification is important? It is important because center involving macular edema require pharmacotherapy and non-center involving macular edema can be treated with focal laser. Today, anti-VEGF agents are the mainstay of treatment. These are the most commonly used anti-VEGF agents nowadays. The ranibizumab is the first approved anti-VEGF agent and it is an antibody fragment. And bevacizumab is a monoclonal antibody, binds with all VEGF isoform and it is an off-label drug. Aflibercept is a fusion protein, binds with the VEGF with a higher affinity than bevacizumab and ranibizumab. And dose is Avastin 1.25 to 2.5 milligram per 0.05 ml. Ranibizumab is 0.3 to 0.5 milligram per 0.05 ml. Aflibercept is 2 milligram per 0.05 ml. And these are the some important anti-VEGF trials in diabetic macular edema. RISE and RIDE trial. Here ranibizumab both compared with the both doses found that both doses of ranibizumab effective compared to sham in terms of anatomical and visual acuity improvement. Vivid and Vista trial basically done for aflibercept. 2 mg aflibercept is given every 4 weekly interval compared with 8 weekly interval after initial 5 months doses compared with laser, and found that both regimes were effective and superior to laser photocoagulation. Protocol I compared the ranibizumab monotherapy with ranibizumab plus steroid plus laser with the steroids and laser alone, and found that monotherapy was more effective than other groups. And protocol T compared all the three, the aflibercept, bevacizumab and ranibizumab, and found that all three are effective for DME if visual acuity loss is mild. If visual acuity loss is worse, then aflibercept is more effective in improving visual acuity. Then Yosemite and RIDE trial compared the faricimab with aflibercept and found that it is non-inferior to aflibercept, though anatomical success and visual acuity stability were more with faricimab. In DME, when to treat with anti-VEGF. And no need to inject for these patients, that patient with the non-center involving macular edema, patient having good vision 6.6 to 6.9, if OCT shows single or less than 3.6, we can observe. Because of the mildness of the disease, metabolic control and mild medication can improve in these patients. And on the other hand, we have this patient, there is no benefit in taking injection in this patient, that patient with exudative plaquette macula close to fovea, disorganized inner retinal layer. Even if the macular edema resolved, the visual acuity may not improve in this patient. These are the pictures of drill and exudative plaquette macula. In the middle, we have these patients. That patient with they will get definitely improved after injection. That patient with center involved macular edema, the patient is less than 612, and patients with rapidly progressive or severe edema, we have to inject in these patients. There are different types of regime: fixed monthly, PRN, and treat and extend regime. Fixed monthly regime is nothing in which every month we are injecting, and problem is it is not quite practical and risk of infection is high because every month we are injecting, and there will be huge economic burden and time consuming. Pro-Renata, also known as and when required. In this, after 3 months of initial loading injection, we have to follow up the patient every month, but injection is given only when it is needed. In PRN regime, patient visits every month, but injection is given only when it is needed. When the patient is stable, we are not giving any injection. Treat and extend regime is the monthly injection is given, still stability is achieved. Then we can gradually extend the follow-up by 1 to 2 weeks based on CST and best corrected visual acuity. And maximum extension can be of 12 weeks And if the worsening is seen, then reduces the follow-up period, and minimum is 4 weeks. Under treat and extend regime, patient receives injection at every visit. And there is a rule for treatment, that is 10% CST and 5-letter rule. Start the treatment with the baseline OCT and best corrected visual acuity, and repeat the same in every follow-up visit. If CST is increased by more than 10% and visual acuity is reduced by 5-letter, it is said to be worsening. If the CST is decreased by 10% and visual acuity is improved by 5-letter, it is said to be improvement. And even if the patient is improving or worsening, we have to inject. Inject till stability is achieved. Stability means visual acuity and CST not changing on 2 consecutive visits. How much treatment is required? We can stop the anti-VEGF therapy if the patient's vision has improved to 6/6 and the OCT has become normal. That means the foveal contour has come to normal, and reduction of retinal thickening at the macula, and regression of the neurosensory detachment, and disappearance of the cystic spaces in the neurosensory retina. Even after 5 to 6 injection, if there is no response, we have to ensure systemic control, check and optimize HbA1c, BP, renal status, lipid profile, etc. And we can switch to a different anti-VEGF agent, because every patients may respond to a better molecular structure, different molecular structure. And you can consider intravitreal steroids in chronic DME patients, pseudophakic patients, and patients with high inflammatory component. Think about focal laser. If FFA shows focal leakage, and patients not responding to, and chronic DME patient not responding to anti-VEGF alone, we can consider focal laser, and check for macular ischemia in FFA, and check for OCT biomarkers. Such surgical options can be considered in case of VMT and ERM. These are some of the newer anti-VEGF agents. Faricimab is a bispecific antibody which improves the vascular stability and reduces the leakage. Brolucizumab is a single chain antibody fragment. Less frequent dosing is required for this. And Conbercept is a fusion protein, binds to all VEGF-A, VEGF-B placental growth factor. KS301 is an antibody biopolymer conjugate which has long-lasting effect. Novel therapies are gene therapy, pod delivery system of ranibizumab. In summary, as VEGF is the key player in the development of DME, in patients with DME, anti-VEGF injection provides significant improvement in visual acuity, improve the retinal anatomy, and decreases the diabetic retinopathy score.